the Dementia Researcher podcast, talking careers and research, sharing conference highlights, and so much more.
Hello and welcome to the Dementia Researcher podcast. I'm Adam Smith and this is the fourth and final of our daily highlight shows from the Alzheimer's Association International Conference, or AAIC 2026, taking place in London and online. After 4 packed days, the notebooks are full and the conference has covered an enormous range of work, from biomarkers and clinical trials to care and policy and lived experience, and no one person can possibly take all of it in. So for one final time, we've brought a group of researchers together who've been attending online to compare notes and connect some of the themes and share what deserves a place in our very final roundup of this year's Highlights podcasts. Joining me to look back on the fourth day are Dr. Niying Li, Assistant Professor at the University of Georgia, Dr. Natasha Anita, who is a Research Fellow at Harvard Medical School and Massachusetts General Hospital, and Lillian Morgado, who is a Research Coordinator, who you'll also know from our recent Relay podcast series from Georgia State University. Niying, Natasha, Lillian, welcome to the podcast.
Thank you.
Thank you for having us.
Before we look back over the conference, let's begin with the researchers behind today's recommendation. I'm going to come to you, first of all, Natasha, to introduce yourself and tell us a little bit about your work.
Okay, well, hi, everybody. Nice to meet you. My name is Natasha Anita. I completed my PhD at the University of Toronto, where my research focused on uncovering potential therapeutic targets for depressive and cognitive symptoms among older adults with type 2 diabetes. And this is an important topic because individuals with diabetes are at an increased risk of developing Alzheimer's disease and related dementias, or ADRD for short. And currently, I'm a postdoc or research fellow at Harvard Medical School. And in this role, I study modifiable risk factors for ADRD with a particular focus on cardiometabolic conditions as well as late-life depression. So thank you again for having me.
Great. And you'll have had a busy conference this week because there's so much to cover in your field. Well, thank you very much for joining us. Niying.
My name is Niying. I'm the assistant professor at the University of Georgia College of Pharmacy. My research area is health services research. I'm particularly interested in the disparities in access to care for people with Alzheimer's disease and related dementias. Particularly, I'm interested in access to the new disease-modifying therapies. And another piece of my research is I'm interested in dementia family caregivers because I used to be my mom's only caregiver, so that topic is so dear to my heart. I'm very happy to be here. Thanks for having me.
That's great to have you join us. And again, access to treatments has been another topic that's been so covered, particularly in today.
Yes.
In today's program. But I'd say that the US seems to be ahead of the rest of the world when it comes to that particular challenge.
Yeah, and spoiler alert, I have picked up a few posters on anti-amyloid therapy, real-world implementations, and caregiver perspectives that I'm ready to share later.
Great. Can't wait to hear those. And Lillian, let's come to you now.
My name's Lillian Morgado. Like Adam said, I am a research coordinator at Georgia State University. I right now am working on a lot of qualitative research looking at data sharing between Alzheimer's researchers, as well as the ethics of disclosing biomarker research results to participants.
And of course, if you want to know more about Lillian wasn't just in one podcast. Lillian was on 2 podcasts because you were in one of our B-side shows as well, where we got to talk a little bit more about your career and, of course, on all your work on the peers. So do go check those out. They're not far back in the stream. They're just a few clicks away. Thank you very much for joining us, Lillian.
Happy to be here.
So onward to day 4, and let's get around to talking about those highlights. I'm going to come to you first, Niying. You can give us your first highlight from today's programming.
Yep. I wanted to share first a poster from the Wednesday morning poster session titled Dementia Care Research and Psychosocial Factors, Dementia Care and Health Services Research, because my background is also health services research, so I'm a little bit biased. This poster is titled healthcare providers' perspectives on use of amyloid targeting therapies for Alzheimer's disease in a high poverty U.S. state. The presenting author is Maria Pisu from University of Alabama at Birmingham. We know that, for example, lecanemab, the disease-modifying therapy drug, was approved in 2023. Its uptake has been slowly increasing, particularly in the U.S., but in a lower resource state like Alabama, which is a high poverty medical shortage state, the disease-modifying therapy use is lower. And this study explored providers in Alabama, their perspectives on the barriers to disease-modifying therapy use. And the researchers conducted semi-structured interviews with 15 providers who care for people with Alzheimer's disease in Alabama. They include neurologists, geriatricians, psychiatrists, primary care providers, and 46.5% work in urban areas of Alabama. And the interviews came up with five themes. The first one is that challenges for early diagnosis. They mentioned that they are often seeing delays in recognizing symptoms, the delays in seeking care, so that the patients might miss that critical early stage window, which is the indication for consideration for the disease modifying therapy. So the patient might came in too late. And the second theme is limited availability. That means access to specialists, diagnostic and treatment centers is limited in Alabama. And one person mentioned that the wait time to memory clinic appointment could be 9 to 12 months. And the third theme that came up from the interview is the high economic burden, which include the high cost of the drugs and the limited insurance coverage for tests and diagnostic procedures. And the fourth theme that came up from the interviews was the high travel burden procedure. They mentioned that there's a large travel cost and burden, especially for patients living in rural areas. And the disease-modifying therapy, for example, lecanemab, that's an infusion that you will need every 2 weeks, and also the associated MRI screening, that would incur high frequency of clinical visits. And the fifth challenge that came up from the interview was the unclear benefits of the disease-modifying therapies. The clinicians mentioned that they were unsure about the benefits on important outcomes, such as preservation of independence and memory. And I particularly like this study because last year I published a similar one focusing on the state of Georgia, and Alabama is just located to the left of Georgia. Georgia is a bit similar. Georgia has 150 counties. Out of 150, 129 counties are rural counties with limited supply of physicians of all kinds, primary care physicians, neurologists, and so forth. And rural Georgia also has disproportionately higher AD burden. So we looked at the locations of amyloid PET scan centers in the state of Georgia. We also look at the locations of lecanemab infusion centers in the state of Georgia. And we mapped the distance from people in each of the 155 counties in Georgia to the nearest amyloid PET scan center and to the nearest lecanemab infusion centers. And guess what? There was only 6 at the time of our publication. There were only 6 lecanemab. 6 amyloid PET scan centers in Georgia, and none of them was located in the rural county. And there was only 1 lecanemab infusion center located in the rural county, and most of these facilities clustered around Atlanta. So we only touched on one aspect of access, which is transportation or distance to care. And from this study I saw from Alabama, they also pointed to a very similar issue, which is transportation burden and similar issues with the shortage of medical professionals, because they only mostly they cluster at urban medical research centers.
Yeah. So there's nothing surprising there, is there? Were any of you shocked by those findings? I don't find them shocking, but what they do is absolutely confirm what is the reality on the ground with this, and of course that's singling out a single U.S. state. But as you already highlighted, other states are in the same position, and I mean other countries are even worse, aren't they? I mean. Of course, these anti-amyloid therapies aren't actually licensed everywhere, but I know in the UK where I am, there's all the discussion about those right now is even if we got them tomorrow, we're not ready. The health system isn't geared up to deliver that regular scanning that's needed to get that earlier diagnosis. That we also have really long delays on memory clinics from some, and that varies in different parts of the country. So in some ways, it's kind of good that we have time to prepare rather than failing people by giving them a treatment that they can't then access, which feels almost worse than, I don't know if it is worse, probably not, but it feels slightly worse. Did they present any solutions, Niying?
They do not in this poster, but I think that we are seeing more and more studies of this kind. I think that will be a very important research topic that I would like to see more in the future AAIC conferences.
So I'm going to jump off the back of your highlight just to pick out on one of mine because it is absolutely connected. I don't know if any of you managed to attend the Donanemab session, which was on today. No? Okay. So Nick Fox, who's a neuroimaging world-leading expert at UCL, gave a plenary talk. He outlined how modified titration regimens were reducing ARIA events without compromising amyloid reduction for Donanemab. So they've had a whole new look at titration. But he also presented some really fascinating work that they've done on a new ultra rapid MRI protocol that shortened scan times that you needed while you were on Donanemab considerably. So they went from, I think it was usually 30-minute scans to 7-minute scans. With individual sequences taking only 90 to 100 seconds using 3D images. So you could see a lot, far more people in a much shorter space of time, which makes a massive difference. And this isn't fancy MRI kit. This is, fairly normal, certainly in the UK, NHS MRI scanners that were able to do this. But this is a new protocol that they'd done. And they'd done quite a few things. They presented a lot of the work that they've been wrapping around Donanemab to see if Sarab Neri discussed corticosteroid pre-treatment, and found that it didn't reduce clearance, but it did lower infusion reactions. So they weren't going to recommend it, but it did, again, something that sat alongside that anti-amyloid. And then Dr. Hong Wang shared a 3-year follow-up data showing durable clinical benefits after treatment stopped, which supported that early intervention, that really did matter. And so I've written down here what the takeaway is. So starting Donanemab early reduced the risk of progressing to Alzheimer's disease by 27%. Amyloid stayed low in 75% of participants, remained below amyloid clearance threshold if they caught that early enough. So it's all kind of good news, if you like, to help regulators and to hopefully do some of the things that are going to be needed to make that more open and accessible in healthcare. Thank you very much, Niying, and I hope you didn't mind me jumping off the back of yours. I'll come to you next, Lillian, for your first highlight.
Okay, so one of the luxuries that I love about attending online is you don't have to worry about what day a poster is up. You can see it all week. So there were actually a few posters that I have some highlights for that I really enjoyed. One was empowering voices, enhancing outcomes, co-creating an open source health economic model for national decisions on care in Alzheimer's disease and dementia in Ireland. And that basically is what it says on the tin. The presenter was Raklana Pwang-Kim, I think, and this was from the Royal College of Surgeons in London. And this is just them rolling out and letting everybody know that they're working on this economic model for Alzheimer's disease to make national decisions in Ireland. I found this really exciting because the University of Southern California announced a similar project last year. And I'm going to be really interested to see how those calculations for economic models are weighted and what the results are differently across the two models. Because they're obviously very different healthcare systems and there's different resources and incentives available. It'll be really neat to see which levers are important in both, which ones are more important in others, all that stuff.
I think the charities in the past have really led that charge, haven't they, on making the economic case to talk about the economic burden of Alzheimer's disease, how it takes all that carer time and what that really costs, and taking away people out of the workforce early, and to make an argument for saying that the treatments you think are expensive would actually pay for themselves if we address this. Never mind trying to then put a cost on the awfulness of disease or the cost of suffering, which I know economists do still try to quantify. That's really good. And so I guess they hadn't moved to implementation yet. They were still just working on the policy.
No, they're still working on it. So that's the sort of thing I'm going to set up a Google alert for, and I'll be nosy and poke in every so often, see where it's at.
Thank you very much. Natasha, let's come to you for your first highlight.
Sure, thank you. So I think my highlight might kind of connect with Niying's highlight about kind of rural communities and kind of access. But so my first highlight was it was during a session called Dementia Diagnosis and Interventions at the Primary Care Level and among underrepresented populations. And if you look on the program, I believe it's under Dr. Nicholas Farina. However, the person who actually gave the talk was Dr. Victoria Mutisa, so on behalf of Dr. Farina. And so Dr. Victoria Mutisa was from the Africa Institute of Mental and Brain Health. And the title of her specific talk was Dementia Knowledge and Attitudes in Makueni County, Kenya, Regional Gaps and the Need for Comprehensive Education. And so I always love attending talks that are not really, related to the work that I'm doing directly. I don't really work in Kenya. I work in the United States and have previously worked in Canada. But it's nice to kind of see, how the field is in other places around the world. And so her work was really talking about the misconceptions that people have of dementia. And so the idea that a lot of people think that dementia is something that's just a normal part of aging. And so, we know as researchers that it is not. It's really something that we are trying to work towards to prevent and slow. But when you have misconceptions like this, it can lead to fear, to blame, and particularly to community exclusion, which I found particularly interesting just because social isolation is a risk factor for ADRD. And so if you have these misconceptions, then it can kind of lead someone who may have been been okay, or at least been able to prevent some of the symptoms if they're socially excluded early on, that might kind of exacerbate, how they're doing. And another thing was that when you have these misconceptions, it's also a barrier to timely diagnosis. And so if you're excluding them kind of early on, maybe not many people are interacting with someone who's experiencing these symptoms. It might lead to kind of delays in timely diagnosis and access to support and care. And so to really look at this, Dr. Mutiso was talking about basically doing a cross-sectional study. So that's what the bulk of the work focused on. So essentially doing a survey on 630 individuals from that specific area in Kenya, and to really understand how specific factors like sociodemographic, religious factors might relate to dementia stigma and outcomes. And so they use the dementia knowledge assessment scale as well as the dementia attitude scale to kind of get an idea of this. And so what they actually found was that there was actually evidence of positive associations with religious and spiritual practices and dementia attitudes. So meaning that you can actually incorporate a lot of, their beliefs kind of into the care system and actually make use of them. And I think it's particularly important because I believe there's been a lot of work with the idea of spirituality being tied to better outcomes in the ADRD space. And so, when we think about maximizing the benefit of some of the work that we're doing, I think it's nice to kind of integrate it with the specific community, and so that they're more willing to kind of, listen to the research that's out there and also be more comfortable actually receiving that care because it is kind of a lot of the work in the ADRD space is kind of, in the Western world. It's been focused that way for a long time. And so a lot of people think it's not really applicable to their own situation. And so if you kind of, incorporate parts of their culture and their religion, then it can increase uptake. So it was more of a, work in progress. And Dr. Mutisa was saying there's kind of, it's cross-sectional. So there's a need to kind of look at it in more detail. But I was particularly intrigued by it because again, I don't do work in this space, but I love seeing it done. And so it was really nice to see.
So were they kind of thinking about empowering faith? Was that this idea that you could, because we know that people have used religion and faith for their own purposes or to get their own messages across for centuries. Is that the idea, is to make some of those more connections?
I think it's more of because within the community, it seems like there's still that kind of misconception towards aging, and so if you can kind of incorporate, for example, things like prayer that's already happening anyway within the community, but kind of tie that in with things in the ADRD space, so making them more aware. So there's a lot of tie-up community events that I've also seen just within my community. So I am South Asian and I see a lot of, we've got a lot of diabetes in our community. And so a lot of tie-ups between the diabetes associations, like Diabetes Canada, for example, or the American Diabetes Association will do events with like pre-existing South Asian kind of communities. And that way it's not kind of foreign to the community. It helps with uptake. It helps kind of drive the conversation. And so I think that's kind of what they're going for here. It was more of just doing just a cross-sectional survey to see what's going on, and then kind of building off of that to see if we can kind of increase the knowledge and kind of make it a little bit more easier for people to access care as well.
And the AAIC is that great opportunity to step out of your comfort zone and to go look at some posters, to absorb some talks that aren't the usual thing that you would go to. Thank you very much, Natasha. So speaking of lanes, we're going to go round the room again to capture some next round of highlights. And Lillian, I'm going to come back to you. Did you step out of your lane today and absorb something new?
I did, but I don't know if it counts because it was the plenary session. For the purposes of this podcast, yes.
Okay, great. So which one was it? Was that Dag Arsland or was it Zahinor Ismail?
It was Zahinor Ismail, where he was discussing the reasoning behind looking at changes in behavior or personality that are persistent in older adults as potentially, and this is one thing where he was going really technical and it was really cool. So I don't remember all the exact details, but about how that's very important to look at, and behavioral change in behavioral impairment is just as important to look at as cognitive impairment and cognitive change. This was fascinating to me because one of the things he brought up was that in a lot of clinical trials, they use the geriatric depression scale to potentially exclude people from participating. And the time period that they used for that is 1 week, which is crazy because that means if you're otherwise a fine, perfectly happy person, but I don't know, a tree fell on your house last week, then you don't get to participate in research. That doesn't seem logical. So that is an interesting thing to both look at, a new measure to consider when you're looking at a lot of longitudinal things, and then also new processes potentially for enrolling people in clinical trials and research. So that is really cool to me.
I saw the same one. I made a point. I always make a point of at least watching the plenaries. And I've written down some notes here that were new behavioral and personality changes in later life can be signs of neurodegeneration. Mild behavioral impairment can occur in cognitively normal people, but those with subjective decline are more likely to go on to get mild cognitive impairment. And if you saw that change for more than 6 months, that it was significantly likely that they were going to go on to have some kind of neurodegenerative condition. I think I've said that correctly.
That sounds about right to me. So I will say yes.
Thank you very much, Lillian. That's good. Niying, I'm going to come back to you for your second highlight.
My second highlight is another poster called Health System Readiness for Anti-Amyloid Therapies in Alzheimer's Disease, a South American physician survey. The presenting author's name is Belén Custodio from Peruvian Institute of Neurosciences in Lima, Peru. And this is a very interesting study because I have seen most of the real-world implementations studies coming from the US, coming from Western Europe or Japan, and I rarely see studies coming from low middle income countries. And the authors stated that the introduction of these drugs will pose substantial challenges in low middle income countries where the health system face structural workforce and diagnostic constraints. So they administered a cross-sectional survey of physicians who were involved in the clinical management of Alzheimer's disease in South America. They were identified through professional networks, and a total of 74 respondents answered the survey, and over 80% anticipated changes in diagnostic practices with increased indications for MRI and biomarker testing. And a large majority, 89%, agreed that neurology services would require additional resources due to both increased follow-up visit frequency and longer consultation times. And also a large majority agreed that the neurology departments should incorporate clinical guidelines specific to the use of these drugs into their treatment protocols. And as we know, we have the lecanemab best use recommendations and the donanemab best use recommendations. They are published and widely used in the US context. And I am aware that some countries in Western Europe, they have also published their own best use recommendations with regards to these drugs. But from this study, they indicated a need for their own guideline in South America, which I think is very important. And maybe the next AAIC, or maybe down the road, we will see something like this that is being presented at the conference. So I think it's very nice to see that AAIC is giving the stage for a lot of the researchers, clinicians from low middle income countries to present their challenges and their needs.
Thank you very much, Niying. And Natasha, let's come to you for your second.
Yeah, so I did have my highlight, but before I go into that, I appreciated Lillian's point on the plenary just because the GDS, and I did a lot of work with the depressive symptoms, and so we always had our favorite scale among, within the lab. And so there's like the BDI, which is the Beck Depression Inventory, which does capture 2 weeks instead of the 1 week. There's also CESD, so the Center for I think Epidemiological like Depression Scale, which also is a 2 week frame. So it's nice to have that like that length in terms of 1 week. And then we would also do the SKID, which is a structured clinical interview. But that doesn't give you like the depressive symptom burden. It just tells you whether you're depressed or not. So we would use all of them to kind of capture, but I think they probably lean towards the GDS just because it's quick and easy. But it is 1 week, so you kind of have to wait. But anyway, so that was the point that I wanted to make. But For my highlight, you asked about, getting out of your comfort zone. And so I went to a developing topics talk for disease. So it was developing topics in disease continuum and staging. And this was a talk by Dr. Julie Wish from Washington University. And she's a neuroimaging engineer. So I'm not an engineer, I've never taken an engineering course. But she was looking at an amyloid time model. And so essentially the idea of we hear a lot about amyloid positivity. So whether or not someone's positive or negative, but her work was kind of delving into can we look at and estimate how long someone has been amyloid positive for? Because that might tell you how long they've had the disease, and that might inform prevention as well as treatment strategies. And it again comes back to my thinking about diabetes, because when we think about diabetes, again, it's more progressed in terms of what biomarkers and medications we have. But the one thing we think about is like high blood sugar and diabetes duration. And so not just whether you have high blood sugar, but how long have you been that way? And that can really inform, are you given metformin or are you given something that's, further down the line? And so again, that was really interesting to me. Again, some of it, didn't make sense to me 100%, but what I appreciated about Dr. Wish's talk was it was an early morning session and she made a point of even explaining accuracy versus precision, like that concept, just because I think at AAIC, you get a lot of researchers who know that already and don't need that introduction. But you also get a lot of students who are attending for the first time, or even researchers from outside the field. And so that was nice to see. So it was a developing topic, so it's not something that's kind of ready to be used in clinic just yet. But I love the idea of really trying to capture not just amyloid positivity, but really how you're doing and how long have you been that way, and that might really inform things
Yeah.
down the road.
And that really ties in. Did you see and this got released as a press release today as well, so it must have been one of the big news stories, was the Rachel Buckley study that got a press release today.
Yes, I
And
actually got to see the preview, the practice session last week. So it was wonderful to see in real time. But yes.
but that ties in nicely. So that study found that, again, I'm going to read verbatim from my notes so I get this correct. Adults with very high PTau 117 levels were more than twice as high as average levels in the study, had a 78% estimated likelihood of progressing to cognitive impairment within 10 years and roughly a 38% risk within 5 years. So I'm assuming that that means that test had, I don't know, they can't have done that in real people because it's not been 10 years since, unless they've been able to do a retrospective.
Mhm.
uh
Yes. So, I mean, like Rachel Buckley says, uses a lot of like pre-existing data. Over at Harvard, you've got a lot of cohorts you can pull from, and so
yeah.
that's how we've benefited from looking at data. But it's wonderful work because really you're, taking markers that you can just measure just now, and then you can kind of predict that way. And so I think she probably would love this work, and I'm sure she's looked at it already. So I'll speak to her when I get back.
Absolutely. So, and it kind of went on to say that people with moderately elevated levels had a lower but significant risk, with approximately 15% risk over 5 years and 45% risk over 10 years, which really kind of sets us up for this idea. And I was asking my colleague Amanda a couple of years ago now, saying, well, surely if we start to put this in as like a public health test when you turn 40 years old as part of your kind of turning midlife MOT, can we just test people every couple of years to look at amyloid? And then surely within so much time, you'll be able to say, okay, you're at higher risk here, which might, even if it can't fix it, it might force people to do some of those lifestyle factors
Mhm. Yeah.
that we
And
want people.
there's no negative like thing that comes out of like having a healthy lifestyle, right? So even if it's with ADRD again, it's there's so many things that can contribute to that. But if you're living a healthy life, you're staving off, you're slowing things like diabetes, heart disease, etc. So there's nothing bad that can come out of having a healthy lifestyle.
No, and also as well, I think when people, I think it's very hard to motivate people in middle age to say, hey, you need to
Mhm.
be healthier to not have
Yes.
Alzheimer's disease in 35 years' time. However, if you can say, oh, look, we've got this is your risk now, and we've got a test that
Mhm.
proves this. I, I,
Mhm.
I don't know. If I got that information, I think I'd be more likely to act upon that than
For sure. I think
perhaps.
a lot of science studies, I think, and Rachel was kind of highlighting in her talk where you always talk hear about relative risk. So it's very specific. It'll be like compared to this specific scenario, you're likely to get Alzheimer's in 5 years. But that makes no sense to the public, and it has to make sense to the public for them to act. And so I think Rachel's work will be a great way to kind of get people moving.
Absolutely. Thank you very much, Natasha. So I'm going to come back round for another round of highlights, and I'm going to come to you first, Niying.
Sure. This is another poster titled Deciding About Anti-Amyloid Drugs, a Qualitative Study of Prescribers, Patients, and Caregivers. The presenting author is Justin Clapp from the University of Pennsylvania. They have a very clear research question. They wanted to know how caregivers, patients, and clinicians determine whether a patient should receive anti-amyloid treatment. They interviewed 38 patients and caregivers considering anti-amyloid drugs and also interviewed 10 physicians who prescribe them. And they found that the patients and caregivers who declined treatment, they reasoned that the burdens and the risks of side effects were the main reasons to decline the treatment. And the patients and caregivers who decided to undergo the treatment said there was no choice than to do something. And they think that receiving treatment as contributing to medical research progress. And the clinicians, their perspectives are they are weighing the clinical judgment against appropriate use guidelines, and they're also deciding which aspects of treatment they should issue judgment on and which should be left to patients and their families. And I think it's a very interesting study because they interviewed uh, all the stakeholders, the patients themselves, the family caregivers, and the physicians who actually prescribe the drugs. And I'm very surprised to hear the caregivers saying the caregivers are being very altruistic. They're saying that they want to contribute to medical research progress. And something also very interesting is that the physicians mentioned that they are weighing the realities versus the best use recommendations. And this study reminds me of some of the previous real world implementation studies using the insurance claims data that indicated that even though the best use recommendations recommended against using these drugs on people with a history of stroke, against people who are on anti-platelet platelet drugs, but using the real world insurance claims data, we can still see some patients who actually had a previous stroke but also get on these drugs. And but they're very, very small. The number is very small. And
And
I
was that
remember
because of not following the guidance, or because the patients really pushed to access them, or
that is
did
a
they?
really good question, and I don't know the answer to it. But the paper mentioned that uh, they were being very closely monitored by the physicians. So I would imagine this is a very complex decision making. And from the study, I can see that the the caregivers, particularly from the patient's family side, they're seeing a lot of hope. They wanted to do something better than not to do anything, even though they're aware of the side effects and the risks. Um, so maybe the patients and the caregivers they kind of push to give it a try. And yeah, it's so the physicians they are making some hard decisions now.
I think it must be quite hard to say no, mustn't it? When it's not like you've got an alternative. It's not like you can say, with I guess in cancer, there's usually there's more than a plan A. There's a plan A, B, C, and D. In Alzheimer's at the moment, there is no plan A, B, C, and D. So if somebody's really sat in front of you, desperate for help, I think that it's more likely to say, on the balance of risk, we'll try it. Gus, how is it possibly going to make things worse? I guess for some people it might, but for others, as far as they're concerned, life's as bad as it's going to get. and it's worth the risk of whatever the negative reaction of that treatment might be.
Yeah, and if they're being closely monitored by physicians, maybe after several doses, they will stop the treatment.
Yeah, absolutely. Thank you very much. Natasha, I'll come to you for your third highlight.
Third highlight. But I mean, I would like to highlight the full session, honestly. It's called Inflammatory and Reproductive Health Pathways Contributing to Women's Higher Risk of Alzheimer's Disease. So it was chaired by Dr. Jennifer Rabin, or Jenny as we call her. She was at Sunnybrook when I trained there at the University of Toronto. So we know each other well. But one talk that stood out, though, was Dr. Erin Sunderman of UCSD, and I did spend a little bit of time there as well. And she spoke about neuroinflammatory correlates of tau PET burden in ApoE4 status of older females at risk for Alzheimer's disease. Again, the whole session, I think the theme was a lot of just the idea that women have a higher risk of Alzheimer's disease. And we hear this a lot now, but why might that be? What are the potential mechanisms? And so her work, or Dr. Sunderman's work, was kind of looking at females having a high tau burden and then what might be driving that. And so neuroinflammation has been kind of thrown around as a potential mechanism. And so this was, I have to find the actual acronym, but it was WTIS, Women Something Study. You could do your research and figure it out. But Dr. Sarah Banks from UCSC is also on that. And so hopefully that will help listeners figure out which study that was. But essentially, it's a study of older females over the age of 65 who've got no kind of cognitive issues, but you're kind of tracking them over time. And so basically, to summarize findings on a higher level, a lot of neuroinflammation was associated with kind of these cognitive issues. But I think the overlying theme or overarching theme was we think about neuroinflammation as being kind of bad sometimes, but it's not. I'm going to go back to diabetes, but it's not like, high blood sugar is bad for you, period. It's more of these biomarkers go up and down. And I think she highlighted TREM1 as like a state-specific immune response. So you really have to watch if it's low or high, but that alone doesn't tell you what's going on. You have to figure, like, it can be good in certain situations and not. And so there's a lot of nuances. And I found that fascinating because the story is not that simple. And so that just means, it warrants further research.
And I have to excuse my naivety in this. Were women more likely to have neuroinflammation as a result of some of the hormone and sex differences that we see in women?
Yeah, so they were kind of talking about the bias, so the female bias and the male bias in terms of your immune system. And so there's a lot of diseases, autoimmune diseases, that tend to skew towards females. And so kind of pointing towards that perhaps women have more inflammation, and that might tie into the increased risk. And so kind of looking at that. And so there's a nice chart that they had, or Dr. Sunderman had, about like what specific diseases. So again, looking at other diseases for ideas, right? So a lot of these women, you're looking at older women, so likely they'll have other comorbidities. Just think about menopause as well. And so this, again, it's still, it was a smaller study. So I don't know if it was 50 or 60 people, but again, it's just kind of hypothesis generating in terms of, you should kind of look into this. And when we look at data, that not just controlling for sex, but really trying to stratify different groups, because you can't just look at males versus females. You also have to consider life stage, because these markers they were showing did differ depending on where you were at.
It's been wonderful to see to see that all that work that going on to look at sex differences in gender, which there's been, multiple sessions on that specific topic, haven't there? Across every day there's been something on that. You must have had a busy week if that's your area. And of course, I should put a plug in for our Explored Women's Brain Health podcast, which we have the very next episode to come out after this show will be one that looks at menopause and women's brain health. And that show is going to be out in 2 weeks' time. So do check that out. Thank you very much, Natasha. Actually, I'm going to jump on the back of you because you mentioned tau briefly there. And so I'm quite surprised, and this is because, of course, we have a real variety of guests, that tau has been discussed very little in any of our podcasts over the last few years. but it's been a super hot topic actually at the conference. So I hope you don't think that tau's not been explored here, because it absolutely has. And one of the studies that's been presented this week was, I don't think it was necessarily today, so I'm breaking my own rules, but Professor Kath Mummery from UCL presented results from a phase 2 Biogen drug trial called Donanemab. And the strongest results compared to placebo were seen in the 60 milligram dose, which slowed cognitive decline across different methods of measuring disease progression. 42% Alzheimer disease assessment scale, cognitive subscale, and 50% on the MMSE. It slowed cognitive decline, and 26% on the clinical dementia rating. So the Celia data provided some of the clearest evidence that reducing tau pathology, this was a tau drug, but the Celia data provided some of the clearest evidence that reducing tau pathology can translate into clinically meaningful benefit. And the magnitude of tau reaction and cognitive benefit of Celia is amongst some of the more compelling reported to date in Alzheimer's disease drug development. So super exciting results from this phase 2 Donanemab drug trial that they're going to progress into phase 3, and that's an anti-tau therapy. Did anybody else see that results? Niying, I feel like you're all over the drug trials.
I feel like I'm so sorry, I missed that. Yeah, that will be interesting to see if that becomes a real drug marketed in the world, how that compares to the current drugs that we have.
Well, a 50% slowing on MMSE seems significant.
And did any of the presentations mention anything like ARIA that we have in the disease modifying therapy so far?
So the study also found that Donanemab reduced CSF tau levels by 50 to 65%. No mention of ARIA in the news item. We might want to go check out the talk again, see if that question came up. But I think on the recorded talks, I don't think we always get the Q&A at the end, do we?
Oh, I don't think so.
So if it wasn't presented, you wouldn't necessarily have the Q&A at the end where inevitably somebody probably asked that question. But yeah, that study found that it reduced CSF tau levels by 50 to 65%, and it's the first of its kind of trial, and that'll go on to phase 3, hopefully soon. Thank you very much. So Lillian, you've been very patient in waiting, so why don't you give us your final highlight?
Yeah, my final highlight would probably be the panel that was considerations for the progression of Alzheimer's disease from cognitively unimpaired to cognitive impairment, weighing on the risks. And I am a little biased because Jillian Arias is the PI that I work under, and she was on this panel. What really interested me in this one was looking a lot at the influence of PTau 217 at the progress of the disease. The Mayo Clinic put together a really cool presentation, and they had an awesome study where they confirmed that there's a very strong link between PTau 17 and disease progression, and are working on a model that they can provide to researchers. The other thing that was really cool about their study is that they were able to capture outcomes that happened after people left the study. And one of the things they found was 2/3 of incident dementia happened after those people left the study. So I'm definitely going to be looking a little more into that and seeing how they capture that, because that's very exciting information.
That is really good. And we saw that in one of our podcasts earlier in the week. We were talking about how the Fingers trial had that alumni program to try and stay connected to former participants, which I think is always beneficial. Thank you very much, Lillian. I'm not going to follow up on that because we are getting super tight on time. And I'm very conscious as well that you've all had some posters this week. So I do want to give you just 1 minute each to put a plug in for your own posters. Well, the online platform is there. People are still going to have 30 days to go away and look these up. So Lillian, I'll stick with you. Give us a plug for your poster.
So I don't have a poster, but I did help Professor Arias with her part of the presentation for considerations for the progress of Alzheimer's disease. panel. So please feel free to check that out. She's looking into the ethical implications of sharing biomarker information. There's a lot, folks assume that there are a lot more legal protections than there are for this types of information and the sort of implications and vulnerabilities that people have if they receive this information.
Wonderful. Does that touch on genetic counseling and things like that as well? Is that
Not on genetic counseling. So genetic information is more protected than things like blood-based biomarkers. And that's one of the issues is folks assume that all of the protections that are in place for genetic things are in place for these blood-based biomarkers, and they're not.
interesting? Fascinating. So go look that up. Niying, why don't we look for your poster?
Thank you. My poster is a virtual one titled Racial and Regional Disparities in Mortality from Alzheimer's and Related Dementias in the United States, 2013 to 2023. This is a collaboration between Emory University and myself. The presenting author's name is Tej-Shah, Tejshah. We used mortality data from CDC Wonder from the U.S. Centers for Disease Control. We look at the racial and regional disparities in ADRD mortality across the U.S. over the last decade from 2013 to 2023. And we are also particularly interested in the mortality by dementia type, AD, Alzheimer's disease versus vascular dementia. A few things that stood out from this one is that the south of the U.S. They had higher ADRD mortality, but only in 2023 they were overtaken by New England, which is a little bit interesting because in the south, the southern part of the U.S. is also located on the area which we call the stroke belt, where a lot of people have stroke, and it's also have the southern U.S. also has higher diabetes prevalence. So I'm not surprised to see historically the South had higher ADRD mortality, but what's happening in New England, that's something we're not sure about. So that is an interesting poster.
Fascinating. Definitely worth a look. We have a similar thing in the UK. There's this kind of belt that starts from around Newcastle and goes across the north of England, where mortality is, like 5 years less than other parts of the country.
That area is an industrial area, right?
Yeah, traditionally, yeah, same
Mhm.
kind of heartland. Thank you very much, Niying and Natasha.
My poster, yes. So it's number 2500, if I recall correctly, and it's on underrepresented groups. So it's using the Solinka data set. Solinka stands for the Study of Latinos Investigation of Neurocognitive Aging. And essentially, it's the largest cognitive aging study of Latinos living in the US. So it's the largest minority group in the US, but there's not much research done in this population, despite the fact that they are at the highest risk of developing ADRD by the year 2060. So we took a look at metformin use and cognitive decline over time. And so if you're interested, please check out my poster.
Fantastic. Thank you so much. So we really are out of time. But I do want to, because this is the last show, I think it's important that we reflect a little bit, because by the last day of the conference, kind of individual presentations start to kind of merge into one and present a slightly bigger picture, don't they? And I'm interested, I'll stick with you, Natasha. Do you get a sense after the 4 days of the conference that what's the kind of emerging themes and what's the big picture, do you think?
The big picture for me, definitely that there's a lot of cool tools out there to kind of, whether it's biomarkers or neuroimaging or even things like digital assessments that are coming up as well. So I think you get the idea that there's a lot of people trying to tackle this problem and from very different angles, and they're all equally important. And we all need to work together. So that's the overarching theme. But the thing that I've loved about this year's AAIC is that there's a huge focus on understudied populations, whether that be underrepresented in terms of, for example, like my work on Latinos in the US, but also just other countries that haven't been represented very well in the ADRD space. I'm seeing specific sessions for just that. And also, I think I kind of alluded to earlier, but the importance of looking at women in particular and really diving deep. And so those are the themes that I've caught on.
And it's great to, to have Alzheimer's Association, who are such a great international supporter of that research, not just in providing a platform for it to be presented, but funding it as well. I mean, a lot of, funding internationally in the way that they do. They're such a unique charity and funder in that way that they're one of our funders as well at Dementia Researcher. I'm really grateful for that leadership that they provide in that space. And Niying, what about you? You got a
I agree. I agree with everything that Natasha just mentioned, and I'm going to add a few more things. I see a lot of emphasis on early diagnosis or how to facilitate early diagnosis using all these emerging tools, and how can we empower primary care physicians to be comfortable using these new technologies, and also legal ethical implications of like PTau 217. So I think this is a really promising area because this early stage early diagnosis window will potentially make you eligible for the current medications, and be able to participate in clinical trials, and getting diagnosed early help you and your family plan ahead, think about what to do next. So I think this is a really good synergy that we are all looking at. How can we better get more people diagnosed early? And another interesting thing that I found, even though I didn't find a lot of sessions on this, but I identify a group of posters on the potential use of shingle vaccines to prevent Alzheimer's disease in the future. I'm seeing a clinical trial protocol in Finland. They wanted to do something with the shingles vaccine, and if that if that becomes a viable path, that means we can prevent the disease with very low cost, which is something I'm very much looking forward to.
Thank you very much. And what about you, Lillian?
I feel like Niying and Natasha really hit the nail on the head, but I feel like the theme of this year was kind of refinement. We have good measures. We have good tools. Now, what do we do to make sure we figure out the proper situations and how to use them right? And I think that's a really exciting stage for all this research to be in.
That was perfect, succinct, and a great reflection. I completely agree. I think for me, I agree with everything you've said. Of course, I think there's been so much talk about biomarkers, drugs, and anti-amyloid is still up there. I think artificial intelligence, we haven't mentioned that today. I can't get through a podcast without mentioning AI, but it's been really exciting to see some of the practical ways that this is potentially getting used. I'd just like to see, I've seen a lot of discoveries and a lot of cool research presented this week across posters and some of the smaller talks and the big ones. I think we just got to crack on and put it into use. It feels, and we're still a little bit risk averse, but I think if I was a person living with dementia watching this at home right now, I would be sat there banging saying, yeah, this is great. Let's use it. All these new cognitive measures, the digital tools, the drugs, the therapies, the improved health systems, let's get this all into use, I think, and try and close that gap between discovery and implementation. Niying, Natasha, Lillian, thank you so much for joining me and helping to bring the fourth day and final day of AAIC 2026 into focus. I say final day, of course, but there is the AAIC for All conference, which is going to be happening tomorrow. It is still free. There are still some amazing presentations planned as part of that program. So do check that out as well. But that brings our AAIC Highlights podcast for this year to a close. Across the week, our guests have guided us through major findings, overlooked posters, and emerging questions across the whole of AAIC. And you can find profiles on all of today's guests and all of this week's guests and all the highlights and much more on our website at dementiaresearcher.nihr.ac.uk. Look for hashtag AIC26 in pretty much every social media platform I've been to this week. And of course, I think all the talks are going to be available for the next 28 days on the Alzheimer's Association platform, which is aic.als.org. So do check those out for the next 28 days. Thank you, all of you, for joining us.
Thank you for having us.
Thank you for having
us.
I'm Adam Smith, and you've been listening to the Dementia Researcher podcast. Goodbye.
The Dementia Researcher podcast was brought to you by University College London with generous funding from the National Institute for Health and Care Research, Alzheimer's Research UK, Alzheimer's Society, Alzheimer's Association, and Race Against Dementia. dementiaresearcher.nihr.ac.uk